I want to involve you folks a little bit. I think and know we've got a lot of people who've got experience and expertise to share. And so I'm going to ask you for some volunteers for cases and stuff like that. And I won't be able to call on all of you. If nobody volunteers, I may pick somebody out I know or don't know. So it won't be to embarrass you, it'll be to try to help us all understand different angles. And one other comment, I'm not going to talk much about demography. Roger's already mentioned the demographics, several have mentioned the demographics. I think the most telling thing about what's going on with demographics right now is almost all the driving schools are now converting from training 16-year-olds how to drive to screening and helping older people how to drive. And that's because they want to stay in existence. And back 3 years ago, the percentage of the Maine population that was under 18 dropped below the number of those over 65 and is rapidly rising. We will exceed, the nation is concerned about what happens when 20% of the population gets over 65. And Maine will probably do it in the next couple of years. It may take until 2030 for the rest of the country to catch up with us. But this demographic is directing a lot of stuff, and the point of all this is that, what's that? I'm invisible. Oh, okay. Okay, they can see the back of my head. I'm not sure I want them to. So where's the camera pointing? Is this way? This way? Okay. More this way.
There you go.
Okay.
Right there.
I can't move. My point is that even though we've only going to have 7,000 or maybe only 4,000 geriatricians in the country, we can't do it with geriatricians. We can't do it with neurologists. That's the point of those statistics. And the reality is, just like the driver ed people, your population is going to change. So that's why you guys are here. I'm preaching to the converted, but help preach it to your colleagues as well, because all docs are going to have to know a lot more about geriatrics in the coming decades. So maybe that's obvious to everybody, but I wanted to make sure. The other thing, since I have trouble with short-term memory, is that I want you all to know that I've got a few freebies here. This is a American Automobile Association, the other AAA organization that puts out a way to screen your patients, family to screen their elders to screen themselves. It's a box of them up there on the table, and if you tell me how many you need in Bangor, I'll send you some to Bangor too. And by the way, Bangor, I'm going to be calling on you folks for cases too. So with that introduction, I'm going to start with the laundry list that Roger gave me here to cover, in addition to driving. And some of it is really advanced directive, and some of it isn't. But advanced directives, by definition, is important. The question is when to bring it up. And the first handout I gave you was an op-ed in the New England Journal of Medicine about a doc who was still feeling guilty 20 years later because one of his first patients as a resident, I think it was, who had bad lung disease. He had never raised the question of establishing advanced directives, and he was saddened to find out that she eventually died despite his having been reminded to bring it up with her, and she died in the ICU, intubated, as I recall. It's a touching article, and everybody who's been in the business has been there, done that. But it's just a good reminder that it's important to bring up. And that brings me to, when do you want to raise it? When do you folks raise it? You clinicians, how do you approach it? Do you do it age-based? Do you remember it every time a 65-year-old comes to your office? When do you start working with your patients to set up advanced directives? I'll come to you, Eastern Maine, in just a minute. Amy.
It's not really physical for anybody over the age of 18 to check off a box, do you have an advanced directive or a living will?
Well, her answer was anybody over the 18, she has it on a checkbox and gets it done. 100%?
Yeah, gets it done, Dan. You just asked about when we asked the question.
She said I didn't ask when she got it done. I shouldn't have asked, I didn't ask that question. Other people, when do you do it? Okay, I got to stay back here. Okay, thank you. Thank you. I want to talk to him, Roger. First physical, okay? And no matter how old. School physicals? I don't either. I can't see how you could do that now. But some people do, they say.
40s, okay.
40s? Yeah. Do you give them something? You just say you got to sign it before you leave? How do you do it, Michelle?
We're pretty consistent for new patient visits, and then also the Medicare physical, but I can't say it happens with every other
Michelle
visit.
Moser says she does it for Medicare patients and the what kind of physical? New patient physical. So you raise it anyway then. Yeah. Any other thoughts? Well, another technique that a lot of people use are after an acute illness. You know, your first visit after hospitalization is a good time to be sure. Because, you know, depending on how old they are, the odds of it being important are a lot smaller than somebody in that stage. So, or you don't have to have been in the hospital either, but that usually people are maybe a little more attentive. Yes?
Now, there's a good book out now, if anyone hasn't heard of it, or maybe everybody has. but-
Atul Gawande.
Yeah, Being Mortal. That gives you some really
Being
good
Mortal,
ways to
that's
answer
very good,
questions.
yes. Being Mortal by Atul Gawande is wonderful. It really is. So that's the when, we fixed that one. How about powers of attorney? Do you talk about powers of attorney? I don't usually. I do ask it when I've got it on a checklist. No? Yes?
I ask everybody, but often I'm asking the power of attorney, actually.
Yes.
Because by the time I'm seeing people, they have advanced dementia. So I'm trying to ascertain who's the POA.
Especially, most of her patients have advanced dementia, and so she's making sure that she has a power of attorney.
You know, there also is the model that it's not an event, it's a process, and that it's revisiting it, and anytime there's a family illness is sometimes an opportunity, and find those opportunities when they may be receptive. The other.
Wait, don't go too fast. I've got to translate here. It's not an event, it's a process, Betsy says, and keep raising it up. And the other time is if there's a family member who's been sick, they may be in the right mood to do something about it then.
And there's a great article, Redefining the Planning and Advanced Care Planning by Terry Freed and Rebecca Sudor, that says, you know, most important is really identifying a power of attorney who understands your values, clarifying for them how much leeway you'll give that power of attorney, and making sure that you've talked with that person, because then they can adapt, and that
No surprise power of attorneys, yeah. Make sure you've talked with them and make sure there's somebody compatible with your values. Yeah, the power of attorney is really quite interesting, and we don't talk about it very much, but the big issue is certainly having somebody you trust. The other thing is I've never known the difference between a durable power of attorney and a healthcare power of attorney and all that jazz. But I just recently discovered that most power of attorneys have an expiration date, or they expire if you become incompetent. So if you use the state form or the one that lawyers put together, they'll cover you for that. But that's why the word durable is important. It doesn't have to actually be in the here's mine. Here, that'll do it. It's important that it not expire if you become incapacitated. That's the message. Now, there's always a section. There's a state form that I gave you, and I've got here. I can show you. You can go online. The state of Maine puts up a advanced directive that I'm not talking power of attorney now. It's just switched back to advanced directive, it's a pretty good advanced directive. It's like all the ones that are in the hospitals, you can specify. You can make additional stipulations. So of course they gave me a page. I filled it. I know too much, and I don't want anybody doing CPR and intubation on me once I'm over 75. I'm sorry, I'm out of range here again, aren't I? You can encourage people to do that. I think this is just for doctors who are in the business. What's that? Hello. Yes, hi. Okay. I thought you wanted to tell me to slow down here. In advanced directives, there is a possibility of making some further stipulations, but what are the limits of advanced directives? Does it always work? Yeah, tell us about it.
Well, I think the advanced directive forms that are created by the state, the ones that the lawyers complete, are so inadequate as to be often unuseful. And I think the most important thing is to have a conversation that is detailed about what a person might expect and be very specific about what their wishes are. I have not found the standard form to be very helpful.
The doctor from Dover Foxcroft does not find it very helpful usually, especially when it's applied, right? The great difficulty is one, go ahead, Amy, yeah.
I was just going to say, I mean, unless you have a specific form at your home that sits on your fridge and has a different color, it tells EMS not to initiate CPR.
Right, you have to have a red A tattooed on your forehead not to be resuscitated these days. It didn't always used to be that way, you know. Some of us are old enough to remember, or I'm old enough to remember, and Roger probably, that it wasn't automatic that you tried to resuscitate everybody, which is what the default is now, which is resulting in a lot of painful terminal weeks of life. That's really a shame.
You can have a pulse on your refrigerator.
A pulse on your refrigerator, right? Yeah, and you can have one on your door, and you're supposed to wear a bracelet, right? Yeah. No CPR tattooed across your chest, and it's hard if you want to take it off. Because the default is automatic full-bore resuscitation, it's a problem, and we've got to do better than we're doing now about that. And a pulsed set of orders. Everybody know what pulsed is. It's the reference for it is in there, but it's the orders. It's a handy set of orders you can write, especially mostly nursing home patients that I'm involved with, to prevent ridiculous things being done. I mean, I see people with terminal cancer being resuscitated. It just does not compute. And it's the world we're suddenly in. And there was a couple of suits from California recently. I heard they were suing because somebody wasn't resuscitated who was terminally ill. It just is nuts. So your generation's got to figure out a better way to do it than we've been doing it. That's all I can say. Okay, so that's advanced directives. Power of attorney is important because there's a lot of sometimes there's no one around to be a good power of attorney. But a kid, you need somebody who cares about the person, and you got to hope they're around when the rubber hits the road. And there are increasing amounts of crime going on involving powers of attorney now, especially here in Maine. And there's some people out there going around offering to be neighbors' power of attorney and really have ulterior motives, with or without a power of attorney. So it's a major danger. So let's and POLST we've already mentioned, and it sounds like a lot of people know about that. Are there any questions about that POLST? I didn't make a copy of it here. I gave you the reference. It's a one-page set of orders. It's a well thought out set of orders if you're dealing in an institution. One other thing about advanced directives is there's always a family member who lives from afar, and suddenly, there's been a caregiver dealing with this for years, and suddenly they come in from California and want to change the rules, and just don't get it, because you don't understand a patient's needs if you haven't lived with them for a while, and that's a huge issue, and it's an argument for involving more family, more of the time, encouraging other family to be informed. You don't want 10 of them calling you, but you do want the one you're primarily dealing with communicating with the rest of the family in an anticipatory way, just so they know what's planned. And you've all done that, yes?
That one that you showed before, that was your own?
Yeah, it's my own personal one, right?
To me, that's the thing that sometimes is not enough detail somewhere so that you can really spell out and understand it ands and buts and ifs, because I think that part of when you look at it, unless you're a person.
For those in Bangor, this lady likes my advanced directives because it's detailed. Yeah, exactly. And it's because of bad things I've seen. Most people think of CPR as magic. It's a button. You just switch it and it happens and it's okay. Everything works. They don't understand. Yes?
I don't know if people, they probably are familiar with the 5 wishes. I think that's
I'm not, no. It sounds like a great children's story.
Yeah, that's really a nice, it's very
gentle, it allows people to express, you know, at the time of my death, I'd like you to play Led Zeppelin or, you know, whatever detail you want to go into. He'll Led Zeppelin.
This lady's bringing up the 5 wishes, which is a system that allows the patient to define ahead of time. It's not free? Yeah. So Google 5 wishes, and it may be a good way to approach this, you're suggesting. Yeah. Anything from Bangor? Okay. Well, let me go on to a couple of the other things. I want to save at least a half an hour to do driving. So other things about anticipatory guidance. First of all, as we've been talking about advanced directives, it's really crucial to have, and several others have said it already, crucial to have family involved. So it's pretty hard to give anticipatory guidance, or anticipatory guidance is a lot more effective if you've got other family involved. And I just would recommend to you that anybody over 65, at least just given their higher risk of having to confront these issues sooner rather than later, should be bringing somebody with them. I mean, not only, you can say it's because 2 people hear better than 1, but the other is so that there's more than one, if there's any dementia going on, you may not miss as much. And more importantly, to communicate back out to family. It may be even more important with men than women. I mean, maybe there are fewer gender differences than there were in the old days, from that slide from the 1950s that you showed. But there still are some, and there will be in this generation. So you got to get at least the couple, if not a kid. Once you perceive any trouble, you got to get a kid in. So that's the first thing about anticipatory guidance. Now, the other thing is the sort of happiness versus risk choices that you want to make jointly. A shared decision-making sort of thing here. It comes up around wandering and getting lost versus getting outside. And it comes up even more, although it's usually it's been decided if somebody's getting lost driving. But some people with early dementia are okay to drive in some circumscribed circumstances, or many are, is the better way to say it. So you want to think about each activity, and that takes some anticipatory guidance, or at least when you know you've got a diagnosis of dementia, and this is a dementia conference, then you want to be thinking about, okay, what are the sorts of decisions that you and the family, you the patient and the family and the doc want to make together? And one of them is about the risk of getting lost or wandering versus being locked in the house. Jane and I saw one patient years ago who was a 75-year-old man. His son was a drug dealer in a large city in Maine, and he'd go out every night to sell drugs, and he'd lock this guy in the house, he'd padlock him in so he couldn't get out if there was a fire or something, and he'd make him sit in one room, be in one room, as I recall. So, the other extreme is taking some risks. My mother had dementia, and she lived over in Vermont, and she liked to, she was one of these 85-pound wonders, but she liked to walk her dog, and she had this huge dog, and she'd insist on walking him, a mile and a half up over these steep Vermont hills that she lived in, and she'd fall down a lot of the time, and she sure as heck had osteoporosis, and she liked to do it in the snow, come hell or high water, she'd do it, and so we had a big family meeting about what is okay to do, and she said, no one's telling me, and so we agreed with her. And she got away with it for several years. The dog would pull her down, and the dog would get away. But she kept testing the equipment, and she survived it maybe too long. The same issue goes on in the home. Jane's already talked about home cameras and drop cam that you set up to run from your phone, and Chip Teal and Damariscotta, who has a much fancier system of a bunch of volunteers who monitor a number of houses, so it takes care of the people who don't have family who can locally monitor, so it provides somebody who can intervene at the same time. It's his American Circle or something like that. I'm giving you the URL for that. And then Jane's also talked about placement. I mean, the big issues are can they stay at home, and how long can they stay at home versus when they have to start, when can they start using daycare to advantage, and that's an overlapping group. And then finally, the placement issues. One of the problems with assisted living is that you get too bad, they won't take you in assisted living. So you got to sneak them in there a month earlier. And so they can't kick you out, or they can kick you out, but it makes it harder for them to kick you out. You can collapse on the floor, I guess. And then from there you graduate to a dementia unit. And boy, I don't know about your dementia units, but a lot of them are discouraging. They lock them in, that's for sure. But there's a big difference between the good, bad, and the ugly. And so shopping for that is very important for families. And that's something that needs to work ahead of time too, because as Jane said, there aren't beds usually. You got to wait 6 months or 2 years to get into these places, the good ones anyway. So that's a piece of anticipatory guidance that's important to share with the family early on. And then there's a couple things about medical screening. Have you ever run into somebody who is badly demented and is in the nursing home, and the family comes in and said they need a mammogram this week? That just gets forgotten. It gets put on autopilot somewhere. Or sigmoidoscopy is another one. Or PSA is probably the worst one. I mean, my God, nobody over probably even 65 should be having PSAs. But you look at it as a Swedish study. But do think about screening. Now, there's some preventive stuff that needs to be done. I mean, certainly Pneumovax if they never had it, although our hospital gives them a Pneumovax on every admission they have for the next 10 years. And the business about the 13-valent versus the 23-valent Pneumovax, I mean, it'd probably get the same protection either way. It's like when the patent runs out, I think. But and talk about patents running out. Well, never mind. I'll tell you that in a minute. When I get to driving, I'll tell you that. So just think about prevention. What matters in prevention is what's the lag time for benefit from the screening procedure. And the lag time for sigmoidoscopies is probably at least 10 years. For PSA is certainly 10 years. And there's been no demonstrable benefit over 65, actually. And for mammograms, it's at least 7 years. So if you've got somebody and that's the usual duration of Alzheimer's disease, of course. So they're really, once you make the diagnosis, it doesn't make a lot of sense to do all this continued screening. Now, if she says, well, I always do this, doctor, shouldn't I do it now? And you can try to explain to her lag time and benefit time and risk from the procedure. But if any of you say that you don't sometimes say, what the hell, do it, then you're lying, because I do too. It reminds me of my sister when we were dealing with my mother. She had a lot of financial trouble dealing with finances, and she'd been a high school teacher in this town for years. And so one of the things we found out is she couldn't write a check anymore, like you were talking about. And so she'd go to there's a local branch office, and one of her students was a teller there, and she'd have her fill out the check. Who do you want it to? I said, it's for so-and-so and so-and-so, and how much should it be? And she'll pull out her papers and tell them how much it was to be. Sometimes the court teller would say, well, that's not right. Let me see those papers. And in a small town, you can get away with that. But there were people who tried to move in with her. We got these calls from the son of a previous minister. He was trying to move in with her. It's complicated, and so I moved over to financial now. You might have noticed, and I'm talking about scams. Scams they're multiplying by factors of 10 every several months, I think, or at least I'm getting the phone calls. Everything but the Brooklyn Bridge I can buy, and I had a couple of patients. I can't remember if Jane met these patients or not, but I had one guy who his garage. His family told me his garage was full of beef, and every 2 months he'd buy a side of beef cut up and store it in the garage. It worked in the winter, not in the summer, and it was more than some of it started in the freezer, but it was spilling out into the floor, And I had another woman who was into toilet paper, and she ordered toilet paper by bulk before the days of Amazon, and she had a garage full of toilet paper, most of which she never got to use. I started to tell you about my sister who was the power of attorney for my mother, and she ran the finances, and she'd get the bills. And she kept, the septic tank kept being pumped out. First every 6 months, then every 3 months, then every month. And she called the septic company and said, why are you pumping this out? You know, you don't need to do it that often. You're just scamming my mother. And he said, Carly, I was her student in English, and when she just tells me she's got to have it done, I'll tell you what, I'll stop charging her, okay? But I can't say no. And so my sister, who was a really compulsive person, she said, I don't know where to put this. I don't know. She finally put it under entertainment. And so I'm going on too long here. But one other issue is who makes the decision on safety. You know, is it the patient? Is it the family? It's less often the doctor, I can tell you. But allowing people to take some risks or to continue to take some risks is, I think, reasonable, and it makes them feel more like the human being they once were and are still trying to be. So I think you know, especially with out-of-state family, it's hard for them. They want to get it all tidied up. The helicopter daughter from California flies in and tries to get everything set up in a week, and it's hard to do in a week. And you got to try things. You got to let them go and try a few things. But you guys know that already, I'm sure. Medication adherence is a big issue, and it depends a little bit on the med. You know, it's not so bad if they're messing up their some meds, like maybe thyroid. It's going to take them a long time to get toxic from, unless they're taking dozens of them at a time. I mean, people first start getting confused about what day it is, and they've got a 7-day box, and they're confused about what day it is, and then they start playing around and start changing medicines and boxes, and that's the point. You got to have somebody there, and to know when that happens, you got to have somebody looking in over their shoulders, and then eventually you can go to that automatic box that says, "Hi, Jane, it's time to take your pills," and pushes them down your throat, or else that tells the police on you, right? Right. So, and I talked about finances. Taxes are the first thing to go, and half the people in the world don't do taxes anyway. But if it's more often the man than the woman who's doing them, and when they start screwing that up, that's an early sign. Checkbooks are next, as has already been said. Of course, no one may be writing a check in a few years, but this generation is going to be writing the check still, and scams, you've really got to talk with them about scams. That's an important anticipatory guidance piece. And you got to talk with family, and they've got to somehow get some sense of what's going on. If they can monitor bank accounts, that's at least a way to prevent some of it. But I don't know. Anybody got solutions for phone scams?
For my grandmother, I ended up having to call and change her number, and then I made it unlisted, because once they're on the list, like once they've been scammed.
Change to an unlisted number, yeah. That's a great idea. Yeah, I like that idea. I may do that myself. Okay, yes, sir.
You can use a representative payee through SMAR or something like that.
Ooh, it's complicated. What did you say?
Representative payee.
A representative payee? Oh, on the checking account. Yeah. You can take over the checking account. Yeah, absolutely. If the bank teller isn't doing it already, right? Okay. The other thing, hygiene is often a thing that pushes you into care. And so monitoring that ahead of time and developing systems for bathing and the other things important are teeth. People neglect their teeth. And so developing systems for flossing and so forth. Alcohol complicates everything. Smoking gets more and more dangerous as you become more and more forgetful because you start burning the house down. Cooking and leaving the stove on and stuff like that. You can disconnect the stove just like you can hide the car keys or disable the car. But the other stove issue is wood stoves. I mean, half the people in Maine burn wood. And wood stoves, if you don't know what you're doing, can get you in trouble quickly, especially this winter. And I wonder about a number of these fires we've heard about here. And of course, you got to be able to cook food to eat, despite Meals on Wheels, but monitor weight and monitor diabetic control. Somebody was talking about hemoglobin A1Cs that were climbing today. That's a good early warning. And then firearms are complicated, but watch out for them. You probably don't have to worry about it if they're not in the home, or if the people who are in the home don't know how to run them, and the ammunition is separate from the guns. But it is an issue for especially men, and it's something to be thinking about. It's tough to just take a guy's guns away from him, though. I'll tell you, it's not a way to have a happy camper. They've got to have enough memory loss that they don't know it happened, don't remember it happened. It's like other things that they're losing. So before I move on to driving, are there any questions about what we've done now? Yes, ma'am.
Maine General is offering free 5 Wishes classes.
5 what?
The 5 Wishes.
Oh, 5 Wishes. Maine General's offering 5 Wishes classes.
One is on May 14th at the ACH at noon, and the other one is here at Thayer on June 11th at 6.
May 14th and 11th, and June 11th. Yep. On the 5 Wishes. Okay. Well, let me switch here. Let me do this. Anybody here have trouble with a family member and driving? I know at least 40% of you have, so go ahead. Tell me about, who's the family member?
My mother.
Uh-huh.
My mother was diagnosed with Alzheimer's.
How old was she then?
82, 83.
Yeah? And
And
tell me about driving.
she did.
She kept driving.
She drove for a while, and then it was such that it became pretty unsafe.
Tell
and
me how you knew it was unsafe. The speed was too fast or too slow?
And the local authorities would
Aided and
say to
abetted
me,
her.
they'd say, your mother's driving up the street pretty fast, and when she was driving up the street, they would just kind of do this.
Yeah.
And that's the local authorities were saying, slow down, lady.
Yeah.
So we got very concerned. She stopped driving at night on her own, good, but she would talk about a friend that she would get in a car with, and she could give directions, and then, we're not going there, you need to turn here, and then she couldn't get her own car where she needed to be. So
a friend helped her get where she wanted to be.
she helped a friend, and then the friend would help her,
I see.
and then I took the keys.
Mm-hmm.
And that was great because I hid the keys until that distant sibling shows up who said, I want to use Ma's card to take her for a ride. Where are the keys? So I get the keys out, and then he leaves them out.
You blew your cover.
Blew the cover. And that worked fine until one day, I got the keys back away. She's severely demented at this point and still home, close to being put in the nursing home. And I was a nurse manager, and one of my coworkers was driving to work, and she said, I was going by your mother's house, and I thought, oh my God, there's a car backing out of the driveway at 5:30, 5:45.
Yeah.
She turned around and followed my mother, who was going extremely fast, almost took out a truck, driving, and she was hoping was coming to my home, followed her, called me, I'm trying to intercept. She pulls into my driveway, we've followed, I run across the lawn, reach in the car, throw that in park, and in her head, she had received a phone call that said I had called her and needed her to come
Great.
immediately.
Thank you very much. One more case, quick one? No? Yes, ma'am. Can you come down?
My 87-year-old grandmother finally stopped driving when she ran a stop sign and crashed into her primary care doctor.
That'll do it. That's 2 red flags. Okay, we can just start from there. There's a lot. We're sort of talking about how to address it when people have got problems. I'll go back a little bit in a minute, but if we don't have time, that's what you guys really want to know is what the hell do I do in these circumstances? So in the first case, there are lots of true things that are universal. One is that the police knew something was wrong. maybe even stop them, and send them on their way and talk to family if they're lucky, and say there's potentially a problem here. Our police are totally different with seniors than they are to kids, which I kind of like. I think I'm getting away with more than I used to. But I have a lady who lived up between here and Bangor, and she had a son in Portland, and she used to drive down every weekend to have dinner with him and stay overnight and then come back home. She was retired, and he was working in Portland. And her husband had been a state policeman, and her son had been a state policeman. Both of them were deceased. The son was killed in the line of duty. And she, on 295, got on the wrong side. There was a bridge construction, and they shunted them over in the other lane. And when it came time to go back to the other lane, she missed that turn, and she was going south on the northbound lane. And everybody dodged around her, and the police stopped her. And she charmed him. She was a charmer, you know. She had lots of verbs. She wasn't all that aphasic. She said, "Oh, my husband used to be a state policeman. You may have known my son, and so I'm very sorry. What was the trouble?" And he told her, and so he called the son, and the son came up and picked her up. But there was no incident report file, there are accidents in which no incident reports or accident reports are filed. So there's a lot of sympathy from the police force. I'm working with the Chiefs of Police organization. They need training on what to do, because they're going to see lots more of this. But that's a good example. Hiding the key, other family members coming in, the helicopter son, is a universal, many times a universal phenomenon. The business of your friend following her, that's probably the best way, if you can't ride in the car, to check on a loved one that you're worried about. You know, at least once a year, even if they don't have dementia, but you've got some reason to worry, and maybe it's early or something, ride with them. Or if they won't let you, which is about true half the time, follow them, whether they know it or not. Because the kinds of errors that your mother made are classic. The most common accidents for an older person are to have trouble coming out of the driveway, and they get hit most often at the driveway. Stop signs are a big problem, and stop lights are a big problem. Or going through, having a red light and going through it, or a green light and stopping is another one. And the confusion of you can read about them in the papers, because the papers pick on older people, I think, a little bit. But an older person who hits the gas instead of the brake, is something wrong. You know, that really should call for an evaluation by you or the family, if there's family around. If there isn't family around, you can call. Anybody can report a dangerous situation to the Bureau of Motor Vehicles. Sometimes they do that with nefarious intent, and it's a little hard. A non-family member who's reporting a problem, the Bureau of Motor Vehicles has been burned several times by non-family members who are trying to get even with a person who doesn't have a problem. So you will find some reluctance on the part of Bureau of Motor Vehicles. Hitting your primary care doctor is no question a warning sign, or hitting anybody for that matter. And in fact, you know, cars with a lot of dents in them that they don't know where they came from is a major concern. So let me switch to my slides here if I can. And can I go up and down? Yes, there we go. Okay. So we formed a senior driver coalition. I've already talked about we've got the examples and epidemiology. We've talked about self and family assessments I just mentioned. I'll talk more about it. And then I'm going to give you some clues of things you can do in the office or things you can encourage family to do. And finally, I'll talk about legal and ethical implications of reporting. I have the misfortune of being the chairman of the Medical Advisory Board to the Bureau of Motor Vehicles, and have been for the last 3 years. So I see a lot of the seedy underside of this whole issue. So we've talked about red flags. I've got on my handout some more, a listing of those red flags that we didn't talk about, and you may want to look at it, see if it coincides with what your own experience. But I've sort of ordered them by seriousness. Going the wrong way, especially on the interstate, is one of them. I don't have hitting your own primary care physician in there, but and I've already mentioned hitting the brakes and gas and error, bad responses at stop signs and lights. Oh, and the speed, you drove too fast. 2/3 drive too slowly, 1/3 drive too fast when they're having speed problems. It's interesting that it's the choice of the two. Unexplained scratches and dents, incorrect signaling, and co-piloting. You mentioned co-piloting too. This phenomenon of having a friend with you to tell you whether to turn left or right and when to stop and start, it's very common in couples. The guy is always driven, he's demented, and mom, who's crippled over with bad kyphosis like this and looking out the windshield, tells him when to stop and start. The problem is it doesn't work in emergencies. It's not a good system. If they're using co-piloting, you got to get them off it. The trouble is that there's usually been a form of co-piloting going on in that couple for decades. And it's the change you're looking for. Anxiety about driving and agitation about it, and obviously getting lost. If people aren't riding, that's the grandchildren test. Do your grandchildren or great-grandchildren usually it is? Do you let your great-grandchildren ride? That's a family question. And almost everybody, and not just the people with dementia, restrict driving as they get older for all the reasons that affect their capability. Let me just give you a quick bit of demography here. I want you to understand that there are 4 different ways to measure how bad senior drivers are compared to youthful driver, or any driver group is. This is a national figures showing the number of fatalities per million miles driven, and the old people look terrible, right? I mean, 4 times worse than the 16-year-olds. And that's fatalities, and that's estimated miles driven. There's a formula DOT uses for calculating how many miles people drive based on their age. If you do it instead by the number of licensed drivers rather than by miles driven, then it's not quite as bad. They're only about as bad as 16-year-olds, not 4 times as bad. Why do you think that is? They don't drive as many miles, yeah. But why would older people have much worse outcomes in frailty? Absolutely. And frailty probably accounts from 1/2 to 2/3 of this difference. So the same accident, doesn't bother a 16-year-old, but it raises havoc with a senior and kills him. And then if you do it by age group versus, and this on the side here now, we've switched to, this is per million miles, this is per miles again, but this is crashes, and these are main data that I'm showing you here now. These are crashes per million miles traveled. Now you can see that they're nowhere near as dangerous to the rest of us as teenagers. And then if you do it by crashes per licensed driver, it looks like this. So when you see somebody quoting statistics on old people driving, look for whether they're doing it by mile or by driver, and whether they're doing it by crashes or fatality. That's my message to you. Why does it happen? As you age, there's an increased response time because of decreased processing speed. You can't really change that. You can change it a little bit, and I'll tell you about that in a minute. But it's sort of like maximal pulse rate. There's a limit beyond which you can go. So your processing speed slows. I used to think I could go faster than my age, 220 minus my age, but or plus my age, but I can't. And then you have diminished metabolism of medications and alcohol. Alcohol is a big problem. If you look at wrong way drivers on the interstate who are over 65, half of them are drunk. And the under 65, they almost all are drunk. The cataracts get worse. That's why a lot of people cut down on their nighttime driving. And there are more cognitive impairments, more dementia and medications and alcohol. And I got to tell you my Ambien story. I have this 60-year-old guy who works at the state, and he's had a lot of psychiatric problems that were well controlled on psych meds. And his psychiatrist gave him had been giving him Ambien for several years, and he was doing fine. And then he had this free sample of when the patent ran out on Ambien, they made Ambien CR. And his psychiatrist said, "Here, try this. You might be able to sleep through the night," because the guy only slept 4 hours and woke up after the Ambien. And he tried that. And the first night, he didn't notice any problem. The second night, he ended up in downtown Portland when he lived in Portland and drove to Augusta, and he was wandering around downtown Portland and he didn't know why. The third time, he doesn't have any memory of what happened, but he was found in an upside down car on the interstate coming up to Augusta. And Ambien CR, just the long acting and his age and probably some other med interactions, were doing it, but meds are a huge issue. And all of them. I mean, you know, the Tylenol PM, I think, puts more of my old people over the edge than I've ever than any other drug. Then there are other things that are of minor importance. Obstructive sleep apnea increases. That's not minor, but obese people, watch out for obstructive sleep apnea. Joint disease means you can't turn your neck as well to see what's coming in your blind spot. Cardiac diseases, MIs and syncopies and arrhythmias, a small percentage of it. Diabetes, all that really matters is hypoglycemia. And for gosh sakes, don't try to get their hemoglobin A1Cs down under 7, okay? We overshot, as everybody's learning. The retiring the keys, this is an important thing. You need to talk. I would add talking about driving to anybody who's over 70 or 75 at the latest, because somebody is going to, in the next 5 years, most of them are going to probably have to retire from driving. And it's better if they think about it now. And it's better that their family does it too. So you want to have family around too, or talk with family about it. And most people restrict themselves to daytime, often restrict themselves to geography, which is okay. It used to be there were rules about over 75, you brought them in to test them more. That's pretty unpopular. Its unpopularity is because it doesn't recognize that there are some people who are 92 who are driving okay. And you can't do it on age, although the risk goes up by age. So it's okay for you to do these questionings and anticipatory guidance by age. I went through the high-risk stuff. Okay, this is the ROADWISE review I want you to know about. I got free copies of it there. It's from AAA. This is available online. It's probably where you usually use it. These are CDs that only work in a PC. They don't work in Macs. But I would suggest each of you who are taking care of patients, each of you clinicians, go through it and understand what's on it. Because when we started the whole senior driver group in Maine, we researched the literature and we found these several written tests correlate best with driving outcomes, crash rates. And then we discovered that this exists. And they did a national study, a sample of it, and this really can detect with fairly high sensitivity people who are destined for trouble that require further evaluation. So I commend it to you and from you to your patients or their families or both. In fact, it wouldn't do any harm to everybody at 75 in your office to say, go home and take this, just make sure you're okay. And it screens for 8 things, high and low visual acuity, useful field of vision that I'm going to show you in a minute, memory and other things. It gives you a report on each test they did, and it gives you a report or tells you instructions on how to do each thing. Takes a partner to do it with. You could have a person with you to help you do it. This is the test of whether they can read a sign behind them by turning their head. I didn't know that trick of having them hold the chair like that, but it works pretty well. But that itself is not a game changer. It has some fairly complex. This is the demo part of the fill in the missing information piece. The question is, can you make the upper figure out of which of the boxes below? And obviously number A here is the right answer. But when they start drawing picnic tables and bicycles with missing strips, it's much, much harder. I challenge any of you to get 100% on that. This is useful field of vision, which is probably the most sensitive test, a sit-down test. And one of the nice things about it is that it is called, vision is in its words. So people think it's a vision test. And they don't appreciate that it's also a processing speed test. Because you have an image in the middle, you may have a truck or a car, and you're going to have to identify more and more quickly which it was, and there'll be something coming at you from one of the quadrants that has a number on it. And this is a Trails B. It's the bigger driver version of the Trails B that we do at MoCA. And everybody who drives should be able to do this faster than 3 minutes. I don't want to meet anybody in the road who can't do it in 2 minutes or less. Try it on yourself. You go 1A, 2B, 3C, until you get up to the L's. And it, clock drawing, and the useful field of vision are the three most useful tests, cognitive tests to correlate with crash rates. The ROADWISE review gives you a report, puts you on a scale, and tells you where you can do. Most of it is go see your doctor. If they come see you, the book you need to have is The Physician's Guide to Assessing and Counseling Older Drivers. I've given you that reference in my handouts. It's online, and chapter 3 is the one that tells you if they come in your office, here are the things you ought to do, and here's what you can train your staff to do, and it includes all the 8 things, everything but the low visual acuity stuff that is in the ROADWISE review. So you can give them ROADWISE review and tell them I'm going to test you myself so I can make a report to BMV, but why don't you practice up with the ROADWISE review? And there are other things you can advise. I had, the type of vehicle makes a difference. I had a little old lady whose husband had died, and she had this big Ram pickup, and she was only 5 feet, and she was climbing up and couldn't even reach the handle to pull herself up with, and had trouble with the pedals. I mean, it's obvious, but sometimes the obvious hasn't been considered, especially if family's not around or isn't engaged. Is it all downhill from there? Well, the answer is probably yes, because on average, people have stopped driving 7 years before they die. Women about 10 years before they die, and men about 5 years before they die. And I think you can guess why that may be. I've got guesses. But is there anything you can do to slow the progression? Well, AARP and AAA both run driver education classes where they go for it's classroom classes. Most of the reasons most of the people go are 55, and you get an insurance discount if you take this class on your car insurance. And there's some stuff in there. They keep trying to prove that it's made a difference in crash rates, and they haven't succeeded. I didn't think that fixing reaction time was possible, but there are now studies using a program that's like what's the one on Luminosity that they advertise on TV all the time. That same organization has spun off a thing called DriveSharp, which is an online program that works on training people to increase their reaction times. And the statistics are impressive. People take that course online, and their crash rates for the subsequent, it's a 3-month course, and their crash rates for the next 2 years anyway in the published literature are much better. And there's another set of interventions too. If they what were they doing? That's the one that really matters. There was another intervention. I know, it was illogical consequences or something. It was a way to increase attentiveness that made a difference as well. They did 4 different groups. I would include that when you have your anticipatory guidance discussion about driving. I would say, do you know about DriveSharp? And DriveSharp is available through American Automobile Association. I think you have to pay $25 to do it. I'm a member of USAA, which is another insurance company, which provides it for free. And I keep going back to it to remind myself of what it's like, but it's hard. It's really hard. And you see the truck or the car, you got to identify that, and then there's a kid running at you from the quadrant, and then they keep flashing it faster and faster times until you screw it up. And then they slow it down again and say, all right, we're going to slow pitch here for you for a while. And then it speeds up again, and again you feel like a fool. But it turns out by the time you get done with all this, people do much better at crash rates. Don't let people co-pilot. Begin thinking about private or public transportation systems, depending on where you live. In Portland, you got Independent Transportation Network, which is a way you can give your car and people will take you wherever you want. You just got to have money to do it, and a car worth getting credits for. Depending on friends is one way. And then I'm involved in trying to start a volunteer transportation program based on the one they've got in Ellsworth and Bar Harbor, where volunteers basically transport people, because people can live at home where they're much more comfortable, even if they've got dementia, early dementia anyway, and they can even drive when they've got early dementia if you put some parameters on it. But you got to retest them, and for God's sakes, tell BMV too, because the trouble is we're revising all the guidelines right now, and you're not even asked right now if you have dementia. That's going to change when we can finally get them to do it. I've been trying to get them to do it for a year, but I'll get there before I die. And we're changing all the rules, so we'll give you some more parameters. We'll put it in terms of what the clinical dementia rating scale is, and mini mental status scores are, and I can give you those if you want. And also, people should be thinking about, what am I going to do when I can't drive? I mean, that's what they got to be thinking about. Have I got somebody who can take me? Have I got family nearby? Can I arrange something else? Begin thinking about it now. The trick is, in bringing up the driving issue, is that it's crucial to living in Maine. I mean, 90% of this is rural. How am I doing, Roger? I got a couple minutes. It's a big deal. And the reality is, you're going to alienate some patients when you bring it up. There's a study in Canada, in Ottawa, where they gave the primary care docs a $25 reward if they would tell them if somebody had an accident. And if they give a report on the patient, and so the docs all piled on that. And then they studied how many patients left their doctor, and they lost 10% of their patients who they reported. But they went to somebody else, so they got reported anyway. And lastly, be careful about alternatives, because there's some consequences. In places like New Zealand, where there's a rule that at 75 you got to be retested, and it still exists in Illinois, and New Hampshire had it until last year. If you look at the cohort of people becoming 75, there's about a 20% drop in people who drive at that age, and that's because they're just not daring to go in and get the test. I'd rather not take the test, I'll just get around along without it. The rates for pedestrian mortality and bicycle mortality triple in that age group as you follow them over the next 5 years. So I've got more to say, but not enough time to say it, so questions for a few minutes? Questions? Yes, ma'am.
I worry about an arbitrary setting of an age.
Everybody does, and it's going away.
Well, people are getting older to work. And last year I was at a conference, and the speaker was 70. His father's 95.
Hey, what's wrong with 70 here?
His father was 95, driving to work every day as a pathologist.
Yeah.
The father, 95.
Yeah, well, I hope I would suggest you urge following the 95-year-old father to work one day a year and seeing how he does, and looking at his car for dents and bumps. But there are a lot of 90-year-olds who do fine, so you don't want to throw out the baby with the wash. Yes, that was the part I left out. The legal responsibility of the physician is an ethical one, not a legal one, and there is legal protection if you report. However, you cannot report anonymously. And it's very powerful. The Board of Licensure, you're right. The Bureau of Motor Vehicles really wants you, I was on the board too. The Bureau of Motor Vehicles really wants reports from physicians. They're much easier to sort through than are ones from family or non-family members. The patient will know that you've reported or can find it out, but you may save lives of the rest of your patients. I've solved all your problems. Great.